The buzz of a mosquito, a sound that heralds the onset of malaria, the disease that, according to the World Health Organization, was responsible for the death of 194,000 Nigerians in 2021. In 2022, the toll dropped slightly to 189,321, only to rise again in 2023 to 200,000. The global body says Nigeria accounted for 30.9% of the global malaria deaths in 2023, with children under 5 and pregnant women highly vulnerable. The figure keeps increasing every year, prompting the call for collaborative efforts to fight malaria. This explains the theme for 2025 World Malaria Day, which says, "Malaria ends with us. Reinvest, reimagine, reignite." A reminder that malaria, a preventable illness, continues to wreak havoc.
Malaria is both preventable and treatable. It continues to pose a serious public health threat, claiming 1 life every minute, with the greatest burden borne by sub-Saharan Africa and children under 5 and pregnant women being particularly vulnerable. Now more than ever, amidst conflict, humanitarian crisis, climate change, and shrinking resources, we must act decisively.
Malaria poses a significant public health challenge in Nigeria, with poverty, poor sanitation, and lack of potable water identified as major causes.
Malaria remains a leading cause of mortality and morbidity in Nigeria. However, with strong leadership, innovation, and sustained investment, malaria elimination is within our reach. Nigeria has witnessed a gradual decline in malaria prevalence, and we eagerly anticipate the results of the upcoming 2025 prevalence survey, which is expected to reflect in our continuous progress.
Here, at the Federal Capital Territory, the administration is making new efforts to reduce the prevalence of malaria by providing free treatment and free immunization for babies. Treated nets and other items to fight the spread of malaria are also being distributed for free. At this event, there was a demonstration of how nursing mothers should use mosquito nets.
We are also strengthening our monitoring systems. We are scaling up interventions. We are collaborating with partners, as you can see today, both local, national, and international. But I said again, the government cannot do it alone. We need health workers, we need parents, we need teachers, we need our religious fathers, we need heads of community to fight malaria. We have given examples here. Sleep under insecticide-treated mosquito nets. Keep your surroundings clean. If you have symptoms of malaria, don't say it is only malaria. Malaria is a killer. Go to the nearest health facility, get treated, and in FCT, for this period, your treatment is free.
The Federal Capital Territory Administration is hopeful that these measures will reduce the exposure of children and pregnant women and eventually force down the number of deaths from malaria in the FCT. Tunji Olanipekun, Arise News.
Right, thank you very much, Tunji, for that report. We have joining us in the studio now, Dr. Shekara Emmanuel. He's the head, Case Management, National Malaria Elimination Program. And our other guest is Dr. Temitope Ipinmoye, Senior Program Manager, Global Fund Malaria Project, Catholic Relief Services. Thank you, both of you gentlemen, for joining us on Newsnight. I mean, the numbers are really staggering. Let me start with you, Dr. Shekara Emmanuel. When you hear that Nigeria still, has a huge burden, the highest global burden of malaria, in spite of the many interventions that we've had even before now. There's been kick-out malaria, all kinds of malaria programs. In spite of that, where we are, where exactly are the challenges? Why this huge burden of malaria?
All right, thank
Dr.
you.
Shekara,
thank you so much for having me. So the huge burden of malaria is of major concern to us as a country. in that it's not something we're enviable about. But however, oftentimes where the challenges lies is not the fact that the government and its partners are not doing as much as they should do, but again, there are concerns around the utilization of interventions in the country. For example, I know the government and partners in the last 1 decade have distributed over 300 million insecticide-treated nets. We have deployed key impactful preventive interventions such as seasonal malaria chemo prevention. Last year alone, we reached over 29 million children. And like you have watched on the TV, the FCT, for example, and even many other states in the country, we provide prompt diagnosis and treatment and surveillance, routine distribution of nets all across the country, and for free, especially in the public health facilities. But however, those interventions are not properly utilized in some instances. For example, in the 2021 Malaria Indicator Survey, the utilization of nets, despite being in fact, the availability of nets was quite high, but utilization still stands low at less than 50%, which means when we go around communities, we still see persons not really utilizing these interventions. Many people, when they have fever, rather than patronize public health facilities where they get these services for free, they would rather walk into a pharmacy and just buy these anti-malarials without actually getting tested. So many times they are not even dealing with malaria, for example. Right. And again, we have issues around data, whether from the private or public health facility, of which the World Health Organization utilizes to model data, and which oftentimes also accounts for the huge figures that we see. And the truth is that the federal government, especially under this dispensation, are not happy with these figures. Nigeria continues to be, the leading, highest burden country for malaria across the globe, and that was what led to the coordinating Minister of Health calling a roundtable rethinking malaria discussion in order to address this concern.
Let me bring in Dr. Ipinmoye to this conversation. Thank you for joining us tonight. I mean, you work with one of the biggest founders, the Global Fund, but I want to ask you, given what we have seen so far, can you pinpoint to any progress whatsoever? Can we measure any progress that we have made? Where are we when it comes to malaria eradication in Nigeria, in your own view?
Right. Thank you so much for having me. Yes, I work with Catholic Relief Services, being the principal recipient on the Global for Malaria grant. And as rightly said, a lot has been done as regards donor-driven activity with respect to malaria elimination in Nigeria. Yes, we have made significant we've had significant achievement. However, we are not yet where we plan to be. If you notice the trend of the data we have, Malaria Indicator Survey, right from year 2020 up to the moment, there has been a downward trend in the malaria prevalence and incidence in Nigeria. However, we are not there yet. Last year, the Honorable Coordinating Minister for Health and Social Welfare, Professor Ali Pate, formed a quorum where we have a committee set to look at the elimination of malaria in Nigeria. And purposely why he did that was just to ensure that we all see this as a challenge and pinpoint some of the challenges that are facing Nigeria with the elimination. As I said, we have tried a lot. We have achieved a lot. We have so many interventions, just like my colleague said, Dr. Shekaraku said. We have so many interventions across all the states where we're implementing Nigeria. But the main challenge we have is around the behavioral aspect of utilization of some of those services. Let me tell you that as we speak in Nigeria, we have incentives at the health facilities, especially for pregnant women. The moment you go at booking, they will give a net, insecticide-treated net, to the woman to ensure that the person sleeps under the net. But as we speak, quite a number of our pregnant women still don't access, these services at the health facility. And also, for the children, upon completion of immunization, they are entitled to have like a net that will be given to them just to ensure that the woman and the child sleep inside this net. But as you speak, quite a number of people still don't access these services. So basically, one of the challenges we're having, as identified by Dr. Shekara, is the behavioral part of it, which has to do with the uptake of services at these health facilities. But for the Global Fund, through CRS, we have actually implemented case management aspect of malaria elimination. We distributed net across all the supported states. We have SMC, as rightly said. We have services for the pregnant women. We have services for the children under 5. And of course, we ensure that we have community-based intervention going through across all the health facilities and the communities that we implement in Nigeria. As we speak, Global Fund through CRS support 13 states in Nigeria, high burden states in Nigeria. And these 13 states, we've actually achieved significant reduction. Well, significant in the sense that, as I said, we're not yet there, but at least we have achieved quite a lot in ensuring that we reduce the burden of malaria in those states. So basically, what we're looking at.
If I may come in here very quickly, let me bring in Dr. Shekarau. I mean, in spite of all of this, the high burden is still very much there. But let's talk about a point you made earlier, behavioral patterns, like self-medication. How can you stress that even further? How risky is it for people to self-medicate? I've heard a lot of people say, it's malaria and typhoid. There's always malaria and typhoid.
Every fever.
Every fever is malaria and typhoid. How dangerous is it not to get tested and treated adequately?
Yeah, thank you so much for that question. And I'm happy you pointed out the malaria typhoid syndrome, which is something that has lingered over the years, quite acceptable in that the body just tells you when you have a fever, it's just been pointing, telling you that there might just be something going on in the body. And so the need for you to patronize a health facility. Luckily, a lot of persons are registered under the NHIA. They have health insurance services, and even
in the rural areas, even the
in some states,
populations. Isn't that where the challenge is? That these health facilities are not even accessible to the ordinary Nigerians.
Well, for the underserved communities, like my colleague had already mentioned, under the Global Fund, under the PMI, and even the World Bank, a lot of states we have various supports. And especially as it pertains to malaria, those facilities are provided with test kits where they can, you walk in there, you have a fever, you get tested. If it is not malaria, other causes are looked out for. So it's quite dangerous that you have a fever and then you are just treating the wrong thing. That's why you hear a lot of persons saying, I bought this malaria medicine and I have been taking malaria, in fact, every month or even before I walked into the studio, somebody was telling me every now and then it takes malaria medicine. That what's happening? And I told him, you don't have malaria. It might just be another thing. Sometimes even stress, might just be the responsible for that.
That's one aspect of it. But I'd like to bring Dr. Ipinmoye back to the conversation because is it possible that we are also dealing with fake and falsified medications? You both have talked about behavioral patterns of Nigerians and how people are supposed to access these nets. We have also seen instances in this country where donor mosquito-treated nets are being sold in open markets That's a challenge NAFDAC has brought up. So we see it happens. We are having falsified medications. We are having free nets that are supposed to be free for pregnant women and children are being sold to them. What are the impacts of all of this? Do they even have impacts at all? Is that something we're looking at? Egypt only became the 45th free malaria nation 6 months ago. Yeah. Nigeria can do it. What's stopping us really? Is it bureaucracy? Is it corruption? Is it inefficiency and our behavioral pattern, or a mix of everything?
Right. Thank you once again for that. So, yes, it's possible for us to achieve the eliminations phase, but it still boils down to that behavioral, effect that I talked about earlier. So when it comes to adulterated commodities such as the ACTs, the artemisinin combination therapy that we use in the management of malaria, getting it from the right source, trust me, all the health facilities, over 7,000 health facilities being supported under the Global Fund support, have tested quality assured medications or anti-malaria in those health facilities. It goes back to what Dr. Shekarayi said. The first step, the rate limiting step, when it comes to elimination or eradication of malaria is making sure that everybody is tested. Every fever case is tested. A lot of people will say it's fever. Let me give you a classical example. Some people even walk into health facilities and they will tell the facility in charge or whoever is in the hospital that, please don't worry, I need anti-malaria. No, we need to go beyond that. For every case of malaria, there must be a confirmed diagnosis. And let me tell you, for all those health facilities that we support, over 7,000 health facilities being supported by the Global Fund, we have RDTs. Those are the malaria rapid diagnostic kits that we use for testing, and the test is free. And for every confirmed case of malaria, we have ACTs available. That is the drug for management of malaria. ACTs are available in those health facilities, and the drugs are equally free. So when you're talking about adulteration, it depends on the source, okay? I know that the NAFDAC is doing a good job as regards to ensuring that we have, quality assured commodities and medicines across the country. But of course, there are some gaps here and there that we need to address. So, but when you go to a government hospital, at least you are rest assured that you are getting the quality medication from these places. Then, as regards maybe theft or probably diversion of such commodities, so we have accountability frameworks that we use to ensure that we have all these commodities being properly accounted for. Yeah, there are lapses, but we try as much as possible to reduce to the barest minimum. So I totally agree. Okay. Once we change, that we can actually achieve,
Yes, indeed. Very quickly, Dr. Shekarayi, I know we need to go. Do you need to take injections after you've taken the anti-malarial tablets? Because I heard every now and again, oh, I've taken the tablets, but I still need to take the injections for malaria to clear. Yes or no? Very quickly.
No, please.
No.
It's totally no.
No. Okay.
Injections are just meant for severe cases. It's just when, we have two types of malaria, for example.
Right.
Uncomplicated and severe. So it's only when the signs and symptoms and then the test indicates that this person has a severe malaria, that's when it's supposed to be given. Those are wrong practices that we see here and there, and it's totally wrong. And oftentimes the patients, they even tell you, if I don't take injection, I don't get better. That's totally wrong.
Dr. Shekarayi, I have to say thank you very much. Dr. Shekarayi Emmanuel is Head Case Management, National Malaria Elimination Program, and Dr. Temitope Ipinmoye, Senior Program Manager, Global Fund Malaria Project, Catholic Relief Services. Thank you for joining us on this day.
Thank you so much for having us.